My name is Lester Thompson, and I'm going to be doing a video tutorial on head and neck differential lesions. I do not have anything to disclose. Let's start off with the first case, and this is a 49-year-old woman excuse me, who presented with a long history of sinusitis and recent onset of obstructive symptoms. Whenever I do a case, I always like to look at the radiology images first. And so in this particular case, here is the radiology image. I think that you can tell there is a very large space over here that has been destroyed. And in fact, the entire medial wall has been lost in this particular region. I'm going to try and have this work fairly easily with going back and forth between the images to drive as well as the virtual slides. So hopefully this will be what you're able to see each time. Whenever I look at an initial case, I always think, okay, what is it that I should be seeing? What should I look at? What are the most important things for me to review? And so in that particular context, I think with all of the sinonasal tract lesions, there are always just a lot of small fragments of tissue. And so it probably is important just to state at the very beginning to try and review all of the material in order to have a meaningful interpretation. As I look at this slide, you can tell that there are sort of three main areas. This first one here with a lot of eosinophilic material, several polypoid fragments over here, and then an area in this space that kind of draws my attention as well. Clearly multiple fragments of bone are also present in the lesion. So let's just go at it a little bit logically and start out over here. I think that you can tell this is a very easy space to examine as just regular old inflammatory sinonasal polyps. I often go to look at high power just to get a better idea of exactly what may be going on with the inflammatory infiltrate as a predominant cell type. And in this case, I think that the eosinophils are the predominant cell type. Sometimes this can be of value to your clinician as they try to manage recalcitrant inflammatory polyps, and they may ask if there is an eosinophilic heavy infiltrate. So I also look specifically to try and make sure that there is not any sort of background spindle cell proliferation or anything else going on within the background stroma of these spaces. And clearly these are just regular old inflammatory polyps. Now, when I look at this particular space, that definitely catches my attention. And as I look at it, I think, wow, you know, there's something a little bit more going on here. First of all, there is a overlying respiratory epithelial component, and then these are very, very well-developed spaces that are dilated below the stroma. And even as I go to slightly intermediate power, I think that you can tell there is a remarkably intact and well-developed basement membrane type material here. That basement membrane material is containing each of these little islands of epithelium, even though clearly they seem to be somewhat proliferative or hyperplastic in overall appearance. And in fact, as I look at spaces like this, you can see that there is a hyperplastic appearance with projections into the lumen of this epithelial component. Now, I think if you go back to the surface, you can see that they kind of do drop off the surface and tend to then be identified kind of invaginating into the underlying stroma, as you can tell here. When I go and look on super high power, I think you can tell again that there is a very well-developed cilial component to this, and in fact the cilia is completely intact. And while there are very rare variants of ciliated carcinoma, for the most part when I see cilia, I can be assured that I'm dealing with a more or less benign lesion. So as I look at that, I can tell that this probably for me is a good example of a respiratory epithelial adenomatoid hamartoma. I don't think that this represents an area of adenocarcinoma. There is no back-to-back gland formation. There's no destructive growth that would be present in that particular space. And then finally, let's go over to this area here, which was much more eosinophilic. And as I look at this, I think all of you can tell that this is a remarkable alternating tide line appearance, showing numerous eosinophils that have degenerated. And in fact, if you go to high power, you can see that they are very, very well developed Charcot-Leyden crystals as a degenerative phenomenon from the eosinophilic degeneration. So this is a nice example of allergic fungal sinusitis. Now, many times trying to find the fungal elements may be quite challenging, and in fact, I don't usually go looking for them specifically in this case, but it would be something that if you wanted to do a stain, I generally do a PAS light green, as that is a much more effective stain than the GMS, to be able to allow me to see this. So ultimately, my diagnosis for this case, in order because of the multitudinal nature of what is present, is the allergic fungal sinusitis, because they need to manage that, the inflammatory polyps, because that can be a clinically recurrent lesion, especially with the eosinophil predominant inflammatory component, and then finally the respiratory epithelial adenomatoid hamartoma, because that really does not make a whole lot of difference in the management of this case at that time. Let us go on now to case number 2. This is a 60-year-old male patient who presented with a long history of sinus congestion and recent pain, and endoscopically was identified to have several large polyps filling the nasal cavity. Again, in this case, you can see from an imaging perspective, there is a large area of opacification of the sinuses with extension out into the nasal cavity. And so when viewing the nasal cavity, you would actually be able to see where this particular tumor was expanding into the nares. Clearly, it is involving the maxillary sinuses and other sinuses, such as the ethmoid and frontal sinus as well. So a very large lesion in this case. Let me change and switch what we're going to be sharing to the actual lesion. And here you can see the virtual slide. So in this case, again, multiple fragments of tissue. And whenever I see multiple fragments of tissue, again, you try to start looking at them to get an idea of what may be present. In this case, there are multiple areas of unremarkable bone, the respiratory epithelium immediately adjacent here with some hemorrhage. However, over here, at least initially when I look at something like this, my index of suspicion is raised for that of a sinonasal papilloma. As you know, they used to be called Schneiderian papillomas, but that particular name has changed, and now they are just called sinonasal papilloma with either inverted, exophytic, or oncocytic used as a descriptor. So when I look at this, I think that there are really areas of a sinonasal polyp or sinonasal papilloma immediately identified here. And then actually in this space immediately adjacent to it, you can tell that there seems to be a transition where there now is slightly more pleomorphism present in this cell population as a comparison to what we were just looking at over here with a very unremarkable squamous or transitional epithelium. So already my index of suspicion that something else is going on has been elevated by seeing these two areas juxtaposed next to each other. However, now as you go up into the rest of this proliferation, I think that you can see that there are multiple fragments of material present here. They have a fairly proliferative appearance to them. When you go to now begin to examine them on higher power, I think you can see that there is quite a bit of remarkable and profound pleomorphism. Actually, I'll go up to higher power so that you're able to see that a little bit easier. And whenever I see this degree of cytologic pleomorphism, you can be assured that you're dealing with a malignant transformation. Now, with the sinonasal papilloma category, one does not need to document destructive invasion in order to be able to qualify it as a carcinoma X sinonasal papilloma, and it is just based on the sheer volume of the material that is present, as you can see here, as well as having a remarkable degree of pleomorphism. Furthermore, areas of comedonecrosis like this, so in other words, genuine comedonecrosis that is present deep within the lesion, this is not something that is surface associated, this is genuinely a comedonecrosis within the tumor. Multiple mitotic figures are usually quite easy to identify, and in fact, there is not really a good number that you're able to use in order to stratify. I tried to do this on a study and turned out that more than 25 generally were seen in carcinoma versus those that were not. And so I don't sit there and count them, but just be aware that you can have multiple mitotic figures. Now, in general, a tumor like this has a overall squamoid appearance. It's transitional, obviously, as an epithelial type, but has more of a overall squamous appearance. And so I would call this particular tumor a poorly differentiated non-keratinizing squamous cell carcinoma. Now, as you know, there are several new variant tumors that come into this differential with things like the INI1 or SMARCB1 deficient carcinoma, the SMARCA deficient carcinomas, etc. But when you see the background, as you do with this, of a benign sinonasal papilloma present concurrently with the lesion, that gives you a good feeling that this is actually just a carcinomatous transformation. They would be staged as a carcinoma in this instance as well, and recognize that the size and the location, depth, and so forth are often quite difficult to be able to render in this instance. Let's go now to case number 3. And in this particular case, it was a 66-year-old woman who presented with evaluation for anosmia. And during that evaluation was identified to have a right nasal polyp. Obviously, a polypectomy was performed, but here you can see the imaging finding, and you can tell that it is a fairly large destructive lesion that expands up into the roof of the nasal cavity. Here is the image that you are able to review, and I think that you can see there are 2 fragments of tissue. They are certainly quite polypoid in their overall appearance. And let's go and look at this lesion. Now, you know, my usual approach is it reactive, inflammatory, or neoplastic? And I think just immediately you can tell that this is going to be a neoplastic lesion. As I look at the surface over here, it seems to be intact with this neoplastic proliferation immediately below the surface. So as I go around the periphery, it's nice to kind of get a feel for, is the lesion arising from that surface or is it actually below it? And I think in this case, it is quite evident that it is below that epithelium. Trying to see pagetoid spread is really what you're doing in that case. There are areas of calcification easily identified as well. But what I think is quite remarkable is the multiple areas of a lobular architectural arrangement as I look at this on intermediate power, and it doesn't really matter which one of these 2 fragments you review. There really is a very well-developed appearance of a lobular architecture. So let's go and look at the lesion on slightly higher power. And I think what is quite easily identified even at this magnification is that this is the dreaded small blue round cell tumor category within the sinonasal tract. Here you can tell that there are multiple small blue round cells. They are arranged in a somewhat sheeted appearance to them, although still maintaining a lobular distribution. But I think what is quite interesting is you have these other cells that seem to be floating around in the background. These really do have quite a different appearance from what you see next to them. They are not really related to the surface at all. This is an area of surface epithelium that has been caught up into it as just a protrusion, but I think as you look at this, you can see that there are these single isolated cells that definitely stand out. When I look at the background of this neoplastic proliferation, there certainly is a number of areas that show a neuroendocrine type differentiation to it with a salt and pepper type nuclear chromatin. So I'm going to cheat by jumping to a special stain in this particular case. This is the stain I would like to show you, and I'm not going to tell you what it is initially until I can actually drive to an area of interest. So remember how I showed you each of those little cells that were present? Well, each of those particular cells are in fact ER positive, and this is estrogen receptor positivity. So ultimately, this actually turned out to be an example of metastatic lobular carcinoma to an olfactory neuroblastoma. So let me just do a new sharing and go back to our presentation for a moment and show you that when I have a small blue round cell differential, this is what I normally do. I will do a CK-Pan P40, synaptophysin, INI1, Desmond, CD99, S100, and CD45RB. That particular approach will allow me to manage all of the lesions that are within the small blue round cell differential, and you can see that I have highlighted them along the side. If you want to use the mnemonic of Mr. Sleep, you certainly would cover the vast majority of them, but you can still see that there really are a large number of these particular lesions included in the differential, and they really can be maximized with this particular panel approach. I usually do the panel because no matter what, if you leave off one of them, that is likely to be the case. So in this example, which happened to be the olfactory neuroblastoma, you can see that the keratin really should not be reactive. However, in this case, the very strong reactivity for that keratin in the isolated cells rather than the rest of them was the tip-off to me that something else was going on, since the rest of the neoplastic population highlighted with synaptophysin and obviously had a sustentacular S100 reactivity. So something to consider as you look at these small blue round cell tumor categories. Let's go on now to case number 4. This is a patient who was 18 years old at initial presentation and had left-sided nasal obstruction with diplopia and proptosis, rhinorrhea, and bilateral headache for 1 year. And in this case, he had imaging that showed an approximately 8 centimeter mass. So here you can tell the image. It is remarkably large in this case and really is quite difficult for the patient to have breathed in this case. Let me do a new sharing. So these are the fragments of tissue. Again, because it's a sinonasal tract case, there are going to be multiple fragments of tissue. And again, the usual approach that I have with these lesions is, as I look at them, initially I always say, is this neoplasia? Is it reactive? Is it inflammatory? And again, I think in this example, it's very clear that we're dealing with something that is neoplastic in this example. Now, I do, as again, try to, as I said previously, try to look at the periphery of the lesion to try and see, is there any surface epithelium? And as I go around to each of these fragments, there really is not a lot of surface epithelium that is present in the tissue. There are areas of ulceration of the surface, as you can see here, that kind of go into the underlying tissue. So let's look at this on slightly higher power. I think that you can tell there is a vague monotony to this. So when I think about tumors in this case, I always try to get an idea of, is there pleomorphism or monotony? And even though it is quite cellular in this example, there is still an overall monotony to the cellular proliferation. There are several vessels present in the background, but I don't really see any well-developed peritheliomatous hyalinization in this case. What is interesting is that there are isolated areas like this that seem to show more of a fascicular architectural arrangement. And in fact, as I begin to look at those areas of fascicular appearance, they seem to be almost a rhabdoid type appearance to it. And let's go and look at another area like this over here. And I would venture to say that in this case, you even have strap cell formation over here. So, of course, the differential diagnosis here, when you think about what's going on in the sinonasal tract, is certainly going to be rhabdomyosarcoma needs to be considered. However, a spindle cell rhabdomyosarcoma in the sinonasal tract is quite uncommon and certainly is not seen very frequently. A malignant peripheral nerve sheath tumor showing rhabdomyoblastic differentiation, often referred to as a malignant triton tumor, would also be a consideration. And finally, one would also have to think about the notion of a biphenotypic sinonasal sarcoma. So I'm going to show a immunohistochemistry here as well. In this example, it happens to be of a myogenin, and I think you can tell that there is a strong nuclear reaction, but only in a subpopulation. So in other words, there are only isolated cells that seem to be reactive, while the rest of the neoplastic proliferation is not. So again, this helps me because if this were a rhabdomyosarcoma, then everything should be positive, not just the isolated areas showing rhabdomyoblastic differentiation. Of course, since we're in the sinonasal tract, you always have to think about a spindle squamous cell carcinoma, and it is well known that spindle squamous cell carcinomas also can have areas of rhabdomyoblastic differentiation. So let me go back to our presentation for a moment, and in this case, show you what I normally do for a spindle cell differential. So again, I am going to get this set and panel in order to be able to get the correct diagnosis. So a CK-pan, S100, SOX10, smooth muscle actin, beta-catenin, TLE1, and STAT6. With that particular panel approach in this example, I would have a sufficient narrowing of my differential diagnosis that, of course, spindle squamous cell carcinoma is always going to be the first thing to consider. And if you have a lack of keratin reactivity completely and still have that as your differential, doing P63 or CK56 would be of help. But you can tell that the mucosal melanoma, synovial sarc, and other smooth muscle and peripheral nerve sheath tumors, glomerulopericytoma, can all be considered. And yet now, because biphenotypic sinonasal sarcoma is the diagnosis that this represents, you can see that the S100 and the smooth muscle actin, both being positive in this case, along with a beta-catenin, is really the only tumor category that fits in this example, with focal desmin or myogenin reactivity seen when they have rhabdomyoblastic differentiation. So it is an important consideration for you to think about when you do a panel approach for any of the small blue round cell or spindle cell lesions within the sinonasal tract in order to get an accurate diagnosis. Case number 5 is a 72-year-old who had a long history of an on-again, off-again neck mass, and it seemed to be staying larger at this particular time. You will notice a very large lesion here where there is an area of calcification present in the background. So let me go and share what you would see in this example. Here you can see a salivary gland lesion. So a little bit different in this case. Whenever I approach a salivary gland, I also like to look first at the periphery to get a feel for what it is that I am reviewing. And I think you will notice in this example, the salivary gland tissue is really very meager at the periphery. While you have a lobulated mass, there is an area of extension of the tumor out over here, and multiple nodules appearing to be destructively invasive out into the surrounding parenchyma. So whenever I have a salivary gland tumor, it is always important to me that there is such a lot of diversity. You really do need to think about what it is that you're going to look at. And so, as I had said in one of my other lectures, pleomorphic adenoma is always the most common thing to identify. And so, in fact, as I go into this particular space, there is a very well-developed area of pleomorphic adenoma. In my view, that is exactly what you're seeing here. There's a background hyalinization. There's an epithelial and myoepithelial proliferation. Now, granted, the amount of chondromyxoid matrix is almost non-existent in this area, and that can often be seen when you're dealing with a cellular pleomorphic adenoma. However, as I go from that area, which is part of the nodule, into this, I think you can immediately see, if I just leave it at that space, that there is clearly a remarkable difference in what you're able to see in this side. And so as I go into this space, I think you can easily identify now that you're dealing with a malignant transformation. And in this case of carcinoma ex pleomorphic adenoma, this is an example of salivary duct carcinoma. And I think when you think about salivary duct carcinoma, it usually has some apocrine morphology present within it. And so as I look at this apocrine morphology, it really is a back-to-back cribiform architecture with a Roman bridge type appearance or punched out architecture. There is profound nuclear pleomorphism along with remarkable increase of mitotic figures, including atypical forms, as you can see in this example. And so whenever I have a tumor like this that has transformed, I usually do 2 markers in this case. The first one would be an androgen receptor, because I would like to be able to confirm that it is apocrine and salivary duct carcinoma, since you can use androgen deprivation therapy for the lesion, as well as getting a P53, since many times the mutation of P53 or overexpression of P53 can certainly be seen. So let me just show you one of these examples here, because I think it's nice to have seen the androgen receptor. And in this case, especially being able to document the 2 differences that you can see between the 2 tumor components. So here you can see the benign pleomorphic adenoma, and you will notice that there is just no reactivity whatsoever. It is completely negative. While when you go into the area of malignant transformation to salivary duct carcinoma, you can tell that that apocrine luminal aspect of each of these neoplastic areas, in fact, has undergone remarkable change and now does strongly express androgen receptor. Now, I'm only showing you one slide. There were several other areas in this case that showed invasive growth out into the periphery, because sometimes if you look at an area like this, you'll say, wow, here's still part of that benign pleomorphic adenoma. So how do you know if it's still an in situ component? Is it just the area of apocrine change? But when you have this degree of cytologic pleomorphism that is just so incredibly profound, as well as having the invasive destructive growth with either perineural or lymphovascular invasion, that is what is able to help you make that particular decision in order to be able to see what is going on. Oh, I thought I was going back to that first slide, but I guess here we are. Sorry about that. But you know, here you can really tell that there is profound nuclear pleomorphism and profound atypia present within it. So while you can have in situ tumors, they are really something that are quite uncommon, and usually there is a destructive invasion by the neoplastic proliferation out into the adjacent parenchyma or through the capsule of the tumor. Let's go on now to case number 6, 52-year-old woman who presented with a slowly growing mass in the parotid gland that recently had increased in size. So again, when I look at the radiology, you can tell that there is quite a large mass lesion that is present here within the salivary gland portion of this patient. It is expanding into the adjacent soft tissues, and you can tell that it is remarkably close to the bone in this case as well. This is an example of the imaging that you can see with, again, a salivary gland parenchyma around the periphery. And I think in this case, you can tell that there are multiple nodules of tumor. They are expanding out into the adjacent tissue with areas over here showing remarkable comedonecrosis. So already I think you can tell that you're dealing with a tumor that is fairly high grade. Again, I usually do try to look in the central portions of these tumors to try and see why they have undergone degeneration or fibrous connective tissue change. But in this case, there was nothing particularly unique in that area. So salivary gland tumors, as you know, can be remarkably variable one to another. You know, there are more than 45 different tumor categories within the World Health Organization classification. So sometimes you just have to look long and hard in order to be able to get a feel for what the tumor is that you may be dealing with. So as I look at this, my sense is that I'm dealing with some sort of glandular proliferation. The cells are somewhat small to medium in size. And in this example area, I don't see too much in the way of nuclear pleomorphism or profound variation. Let's go over to a slightly different area and see what we can see. And in this example, I think actually one of the features that is helpful in the diagnosis begins to be identified, and that is right here. You can see that there are blue granules that are present in the cytoplasm of these malignant cells. And in fact, this is a nice example of acinic differentiation. Let me see if I can show it a little bit differently in another area, where you really do have remarkable pleomorphism present in this case. But then as you drive around, the areas of granularity in the cytoplasm pop out to you. So here you can see again areas of dark blue granules present within the cytoplasm. Areas of early degeneration are easily identified in that space. So as I drive through this, I'm going to go up to the top portion over here because that's where we had regions of comedonecrosis. So you can tell that there has been high-grade transformation. High-grade transformation is usually identified by a sheet-like growth pattern, the presence or absence of comedonecrosis, and a remarkably increased number of mitotic figures. So here you can tell that those particular features are certainly easily identified. But then again, you can see these beautiful little blue granules present within the cytoplasm that would help you to get to a diagnosis of an acinic cell carcinoma. So acinic cell carcinoma, as you know, can undergo high-grade transformation. One of the stains that can be used to confirm the diagnosis is doing a DOG1. DOG1 is usually positive in these cases. Unfortunately, it's not usually maintained in the areas of high-grade transformation. However, that is usually not difficult, because when you see the areas of high-grade transformation, that probably is what you would have focused on initially, and therefore maybe been a little bit misled about the diagnosis. I will say, when I have cases like this where they are going through, if you think about a core needle or a fine needle aspiration, it would not surprise me if this was the area that was sampled, and therefore you may have just said that it was a poorly differentiated carcinoma. Using the Milan system, you may have said that it was just an example of a high-grade or malignancy present. So you may not have been able to see the acinic differentiation. The finding, though, in this case with the high-grade transformation and still the areas of background acinic means that it is just important to look through the entire neoplasm in order to be able to see those particular features well. I would be remiss if I did not mention one of the newer markers that has been identified in acinic cell carcinoma, and that is NR4A3. It is not really commercially available yet, but that particular marker is strongly positive as a nuclear reaction that can be seen in this tumor, and it is present no matter what the grade of the lesion. So again, NR4A3 can be of value in being able to confirm the diagnosis in some of these difficult cases. In case number 7, it was a 70-year-old man who presented with hoarseness and difficulty breathing with a polyp identified along the true vocal cord. If you think about how these lesions present, they are often a remarkably large lesion. They tend to involve the anterior cord space much more frequently than they do the posterior cord, and so this would be one of the tip-offs to the diagnosis. Here is the multiple fragments of tissue, and you can tell that it actually is quite a remarkably large lesion with a lot of fragments of tissue. Now, in the interest of time, obviously, I'm not going to look at all of them, even though that is what we do in our general day-to-day practice. But again, in this example, what I like to do is always look at the periphery first to see, do I have any areas of surface epithelium or not? Now, I can tell you, because I had looked at this slide a little bit earlier, that there is only one area of epithelium, and that is right over here. Now, it is sort of a little bit of cheating for me to go directly to that, but I'm going to tell you why that, for me, is one of the most significant components of this diagnosis. So I've already gone up to a really high power in order to have you look at that particular epithelium. There is a loss of normal maturation to the surface. There is abnormal keratinization at the surface. There is a disruption of the overall organization. And so in my view, this is an example of dysplasia. Now, for me, this is an example of high-grade dysplasia, and it would be moderate to severe. However, whether you want to debate about what the exact nature of the dysplasia is or not, we can discuss separately. But just remember that that particular finding of surface epithelial involvement really helps get you to the diagnosis as you look at the rest of the lesion. So here you can tell that there is, this is stripped off, so it is actually free floating. But you can imagine that probably if the surface had remained intact, you would see areas of transition. Now, unfortunately, when you think about a large polypoid lesion projecting into the luminal aspect of the larynx and occluding the space, it is going to be very difficult to not have ulceration. And so many times all of the surface is ulcerated off, and it is very difficult in that setting to be able to look at it meaningfully. However, let's just look here at the most peripheral area of the lesion, and I think you can tell there is remarkable and profound pleomorphism present in these spindle cells as they now drop off into the underlying stroma. And in fact, no matter where you look, you can still see that there are these remarkable areas of pleomorphic nuclei within cells that are greatly enlarged. Now, in some fields, I think you would tell that there's a spindle cell proliferation, but it doesn't really appear that remarkably pleomorphic, and you have to move from space to space before you actually see another area where there is pleomorphism to the cells. But this is quite a common phenomenon for a spindle squamous cell carcinoma or spindle cell sarcomatoid squamous cell carcinoma, which is what this particular lesion represents. Now, as I look at other areas, you can tell that, again, the area of pleomorphism is quite easily identified. Many times it is a challenge to find mitotic figures. However, I think here you can see one where it is an atypical mitotic figure present in that field. So again, when I look at this, I try to focus on how much pleomorphism is present and how is it related to one another within the background stromal component. Several of the other things to consider in the differential diagnosis would be something like a solitary fibrous tumor. In general, those are much more arranged with collagen that has a keloid-like appearance and a much more refractile quality to it, and generally no atypia. You could, of course, do a STAT6, and that would help you in the diagnostic category. Other lesions like nodular fasciitis, a spindle cell melanoma, and certainly even a inflammatory myofibroblastic pseudotumor can all be included in the differential, but those lesions generally have a completely different immunoprofile, and of course something like an inflammatory myofibroblastic tumor has a much more inflammatory component than what you see in this example. Remember that doing epithelial markers, generally a P40, P63, or CK56 are going to be more meaningful, along with things like a pan-cytokeratin or OSCAR, in order to be able to confirm the diagnosis. Still, 30% of cases will be non-reactive with epithelial with epithelial markers, and therefore you must remember that you can still call it a spindle squamous cell carcinoma, even though you may not have an epithelial marker present. Case number 8 is a 49-year-old woman who presented with a known history of meningioma, but recently presented with a history of pulsatile tinnitus and left conductive hearing loss. Well, as you can see from this lesion as an MRI, there is truly a large mass present within the middle ear space. And so let's go and have a look at that tumor. So there are multiple fragments of tissue. Again, in this case, with any of these head and neck biopsies, they tend to be somewhat small and difficult to interpret. And so clearly in this case, there is not going to be much difference. So you can tell that there is a heavy stromal fibrosis associated with this proliferation. In fact, as I look at the periphery here first, you can tell that there is an intact cuboidal lining that is the normal lining within the middle ear. A small inclusion below the surface, sometimes referred to as tunnel clusters, can certainly be identified within these tumors. So as I look at this, I think all of you can easily tell in this space that there is a very well-developed nested architectural arrangement. In fact, when you go up to high power, there are single isolated cells that have pleomorphism present within them, and yet the overall population does seem to be arranged in a very organoid or nested pattern. So, you know, when I think about the patient's history of meningioma, this really does not look like a meningioma. There isn't really a whirling or swirling. It isn't an epithelioid type appearance to it. Let's go and look at some of the other fragments of tissue just to get a better feel for what may be going on. But the other lesion that you would need to consider is a neuroendocrine tumor. So nowadays they are called middle ear mixed epithelial neuroendocrine tumor as the new name for previous middle ear adenoma or neuroendocrine adenoma of the middle ear. So that particular lesion is still in consideration as I look at this, but for me, an example here of this representing paraganglioma is much more likely to be present. So whenever I have a paraganglioma, I always do an SDH testing. Here you can see the SDH immunohistochemistry. And in this case, it is still intact. So you can tell that the neoplastic cells here have a granular cytoplasmic reactivity that helps to confirm the diagnosis in this case. Now, what I would like to do is just to share for a few moments, when you think about paraganglioma, we used to have that old rule of the rule of 10% bilateral extraadrenal malignant familial or childhood. And of course, that is no longer the case anymore at all. And in fact, 40% or so are now considered to be extraadrenal. Almost all of them are considered to be malignant, even though only 10% metastasize and are therefore put on a risk stratification. And 50% more of these are now considered to be familial. There have been a whole boatload of susceptibility genes that have been identified. Here they are all listed, and I've tried to put them in the shape of P for paraganglioma, but really stating that you should offer some form of testing in order to be able to document at least the most common genes that are seen, which is the SDH gene, so succinate dehydrogenase. As you know, there are 4 different components to it, A, B, C, and D. And in fact, each of these is associated with a different type of tumor. So the SDHB IHC is lost when there's a double hit inactivation. And so really when it is identified, it means that there's a germline mutation in the SDH subunit. And it is a good surrogate marker of molecular alteration. So here is an example of an intact and a lost SDHB. Just a caveat about the loss of SDHB, it can be falsely positive when there's an SDHD mutation, and also you may get a false negative when patients have VHL mutations present when you're testing just the SDHB component. So remember that they are separated out into sympathetic and parasympathetic, the ones in the head and neck most commonly being parasympathetic, and there is a division based on the anatomic location. SDHB much more likely to be seen in the intra-abdominal area, carotid body for SDHC, and then the SDHD is identified in most of the head and neck lesions. So this is why it is clinically important to perform SDH testing whenever you have these, and the SDHB immunohistochemistry is certainly easily available and readily something that can be done in your lab or as a send out. Case number 9. 22-year-old who presented with a rapidly enlarging lateral neck mass. Ultrasound was done of the thyroid and showed storm with multiple microcalcifications within the mass. Here you can tell that there is a very well-developed area of the ultrasound showing multiple microcalcifications, and this is what they mean by thyroid storm. It isn't thyroid storm as in a tumor that has got excess hormone production, but just an example of multiple microcalcifications. Let's go and look at the lesion, and here you can see an example of the digital slide. So immediately you can tell we're in thyroid now, still part of the head and neck, of course, but I had to throw in a thyroid lesion for good measure. You can tell that here is the thyroid parenchyma, and then here is a fairly sizable and large tumor that is filling much of the space. I think there's also, extension here, but let's go and look at that a little bit more closely. So if I look at this lesion, I think you can tell that, first of all, this is a lymphatic channel, and here is tumor present within that particular lymphatic channel. And when I look on high power here, there is certainly colloid production by the tumor. There's remarkable variation in the nuclear size and shape. There is stratification, there is overlapping. So this is clearly a wonderful example of microscopic, at least papillary thyroid carcinoma with capsular invasion and also showing lymphatic invasion over here. Now let's move from that area, and I think you can see that there is a fairly dense fibrous connective tissue band that's separating out into it. And then here you have a neoplastic proliferation. Now it's arranged in a, to my view, biphasic appearance. There are multiple areas that show both a spindle cell morphology as well as a epithelial glandular type proliferation. They kind of interlace with one another and certainly seem to all be arising within the same space. There are areas that show kind of a secretory material present in some areas as well. I think there were areas that had more of a almost whorled appearance, as you can see here. There are some areas that show degeneration or degenerative material. And then there were several areas that did have small calcifications present within them, as you can see in this example over here. So as I look at something like this, my differential diagnosis is always, is this a primary thyroid gland lesion or not? And in this particular case, my view of carcel, which would be carcinoma with thymus-like differentiation, or settle, spindle cell and epithelial tumor with thymus-like differentiation. Settle would be much more likely in this case. But settle does tend to have a much more fibrous connective tissue that separates out between it. It also tends to have much less in the way of pleomorphism and variation than you see in this example, and also tends to have a little bit more in the way of an inflammatory background that is not present here either. I would also think, is this actually an example of a thyroid neoplasm where there is a papillary carcinoma with a spindle cell stroma? Is it a high-grade transformation? In other words, is this an example of undifferentiated carcinoma? And in this case, I don't think that that is the case, given the patient is only in a very young age. So when I go back to the low power, I really, again, get the feeling that the thyroid, even though it has a microscopic papillary carcinoma, is actually stuck on, and that this probably is something else instead. And so let me show you now an immunohistochemistry, and this is an example of TLE1. I don't think that any of you would struggle to agree with me that this is a strong and profound nuclear reaction that helps to confirm a diagnosis of synovial sarcoma in this example. Remember that neoplasms of the head and neck may often present within other organs, and in this case, I do think that it actually does compress the area of the adjacent thyroid, and rather than arising from within the thyroid gland parenchyma itself. This marker clearly does illustrate that you would not have this present in settle, and therefore you can confirm the diagnosis in this example of synovial sarcoma. You could also do a FISH study for the characteristic SS18 or other marker if you chose to do that. We'll end now with case number 10, a 78-year-old female who presented with multiple recurring lesions in the oral cavity over the last few years and was identified to have a leukoplakia on the right mandibular gingiva. Now, when I look at a lesion like this, clearly this is much more than leukoplakia, but this is why so often what the clinician thinks they're telling you and what you're actually looking at is quite remarkably different. So this is the lesion that was submitted for the biopsy. So here you can tell that there is a remarkably large proliferation involving the oral cavity mucosa. Here are two fragments of the tissue. I think what is interesting is if you draw a line across here, though, you can see that most of this particular proliferation is exophytic, although there's clearly an endophytic component to it as well. So it has kind of a biphasic appearance with both the proliferation out into the lumen as well as the proliferation into the adjacent tissue. I think if you look at this as a part of normal, and again over here, this has some abnormality with the area of parakeratinized material and increased parakeratosis. But again, this is well within a normal range in comparison to what you see with this remarkable proliferation here. It is interesting that it is quite blunted as an overall surface, even though it has these areas that expand downward in an endophytic pattern. There is parakeratosis present here, not really well-developed parakeratotic crypting. And of course, as I look at this proliferation and try to come up with a notion of is it atypical or not, I think you can tell as I look at this that it is not atypical. In fact, there is very little in the way of pleomorphism at all as I look at this entire proliferation, no matter where it is I go. And so that is one of the tip-offs to the fact that even though I believe that this is an exceptionally well-differentiated squamous cell carcinoma, the new name for this is actually barniculate carcinoma, and I'm going to show you that here in a moment with a continuation of a different patient. I would like to just show you this person's lesion as well. You can tell that there is a white epithelium or leukoplakia that immediately surrounds the roots of the teeth. And let's go and look at the image for this case. Here you will notice that there is a very well developed squamous epithelium that abruptly transitions on either side to this area of verruciform appearance. There is a corrugation or undulation to the overall proliferation. And in this case, the thickness of the keratosis, which is an orthokeratosis, is about twice that of the thickness of what you see of the epithelium below, with a little bit of reety ridge joining below, and a very light inflammatory infiltrate. But this very abrupt area of transition with this corrugation and remarkably thickened epithelium in this particular context immediately adjacent to and around the tooth is actually quite significant for proliferative verrucous leukoplakia. And so when I think about this case, there is a corrugation with troughs and crests of keratosis in the epithelium, usually a prominent granular layer, loss of the rete ridges, and atrophy for the site, with architectural distortion that is way beyond what you see in cytologic atypia. And then if you think about the development of the carcinoma category, which of course I just mentioned was called barniculate carcinoma, there is parakeratotic crypting and orthokeratosis, very little in the way of pleomorphism or dysplasia, with a greatly thickened epithelium, with a bulky proliferation of verruciform columns that are quite complex and involuted, with thick, clubby, and blunt basal projections. They tend to all be at about the same level, though, and not destroyingly invading into the underlying parenchyma. So if I can end with a few take-home points of always getting the history. Imaging can be the gross for many of the ENT and endocrine organs, and that there is a very good component to use selective panels of immunohistochemistry in order to be able to reach the diagnosis. Thanks very much, and if you have any questions, I think we'll be able to join the questions here in a moment.